Well, good afternoon, everybody, and welcome to this week's Grand Rounds. We're very fortunate today to have from the Department of Geriatric Medicine, Malith Ramasundara, talking to us on a very timely, no pun intended, and appropriate topic in an ageing society, and that is ageing, frailty and geroscience. Malith.
Thank you. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to the elders past and present. This is the 2023 NAIDOC Week poster, this week being NAIDOC Week. The theme this year is For Our Elders, and this beautiful poster was created by artist Bobby Lockyer. And it sort of, I think, exemplifies the role or the value that elders have in Aboriginal and Torres Strait Islander society in terms of the traditions, wisdom, knowledge that they pass down to future generations. I thought I'd just share that at the beginning. So the topic today that I was hoping to present on, and I thank the Grand Rounds Organising Committee for the opportunity to present here, was ageing, frailty and geroscience. So earlier this year, I had the good fortune of attending the annual scientific meeting of the Geriatric Society in Brisbane with a few other colleagues from the geriatric department, and frailty was very much a hot topic at this meeting. I think it's an area where there's emerging evidence and new research. And geroscience is another field which has been around for about 15 years. Many people may not have heard of it, but in the last maybe 5 to 10 years, there's been an explosion of research in this area into ageing biology and the impacts that this has on disease management. So I'll give you the key points at the beginning because it's probably the middle of the day and just in case people have to leave, but ageing occurs at different rates for individuals. There's also a wide variation between fit to frail within the same age group, which we'll show today. Frailty modifies disease expression, and frailty is both measurable and modifiable. And preventing and treating frailty will have profound impacts on individuals, hospital care, society, economy, and the wider community at large. So this is Dexter Kruger. He was Australia's oldest living person. He lived to the amazing age of 111 years. He died in 2021. So he'd be called a super centenarian. So anyone that lives to the age of 110 is given that title. The oldest person ever to have lived in the world is this lady down the bottom, Jean Calment. She lived to the amazing age of 122 years. She was from the south of France, and here she's pictured. This was back in 1995, the picture was taken. She's no longer alive. There's also some other amazing centenarians who have achieved quite great things. So Ruth Firth is been given an Order of Australia medal. She competed in the World Masters Games at the age of 100, and you can see her here throwing a javelin. She started her career in athletics only in her 70s, so it's quite amazing what she's able to achieve in the latter part of her life. Fauja Singh is a British Sikh marathon runner, and he's the world's oldest person to have ever run a marathon. I think his time for the London Marathon was about 6 hours. He's quite an amazing athlete, and he again started training for marathons in his 80s, so it's never too late, I guess. So an interview of some of these people that have achieved remarkable old age, some of the reported traits that people have mentioned are things like regular physical activity, having a sense of meaning or purpose. I think the Japanese refer to this as ikigai or something to that effect. Having a plant-based diet or a Mediterranean diet that's low in meat. Certain eating patterns have been sort of talked about as being traits that might equate to longevity. This concept of not eating till you're completely full, moderation of alcohol, a sense of social connectedness, and religion may play a part in that because of that social network that people generate from from being part of a religion, or perhaps even the stress reduction that religion provides. And close family relationships have certainly been seen as important for people that have achieved remarkable ages of longevity. So life expectancy over the last few centuries has increased, and it's unclear whether we've reached the limit or the threshold of this. You can see that before the 1800s, life expectancy in at least recorded available information averaged between the 30s and 40s. So people lived up until reproductive age, and beyond that often didn't survive. But after the Industrial Revolution in the early 1800s, with increased sanitation, vaccination, pasteurization, all of these sort of aspects, you can see almost a doubling of life expectancy. In the post-war era, after the discovery of antibiotics, you can see that the life expectancy has again continued to increase. And in the last few decades, with better treatments for chronic disease, cancer management, people can be expected to live into their 80s with reasonably good health. It's unclear the trajectory of this, whether this will continue to increase as time goes on, whether we've reached the limit of life expectancy, or whether this might plateau or even decrease because of various factors like air pollution, climate change, antibiotic resistance, or even pandemics, which we've recently all seen. But I think the important thing to highlight here is that life expectancy doesn't necessarily equate to healthy life years. I think if we're getting better at treating various chronic diseases like cancer or cardiovascular disease, people might be expected to live into their older age, but perhaps with more disability. And I guess that doesn't necessarily equate to health span. So here is representation of 3 people, all aged 85. You can see the gentleman on the left, he's got a slow jog. He's possibly outside exercising, he's wearing a hat, and he's almost running, but not a great stride length, but running nonetheless. The person in the middle, who is of indeterminate gender, is walking with a stick, slightly stooped in posture, perhaps slower in their usual activities of daily living, but still perhaps remains independent in all of their self-care needs. And the person on the right, you can see, is bedbound. They're probably dependent for all of their basic ADLs of daily need. But despite the fact that they're significantly different in terms of their function, they're all aged 85 or representations of that. And these are sometimes indicated on the clinical frailty scale, which we'll touch on shortly. So another way to conceptualize this is that people have quite variability in their function. So young adults might have people with quite good function and others with worse function. And then in the age group, similarly, there's variability. You might have older people that have better function than young people. And age itself is not necessarily a marker of function or status in terms of ability to manage independently. So another way to sort of categorize this is by looking at frailty, and that's a better marker of people's function when you graph frailty as a function of function or ability to self-care. When we sort of look at the opposite and graph age on the x-axis and frailty on the y-axis, we see that in the younger age group, there's very little frailty, but there's a exponential growth in the degree of sort of frailty as people get older. And at about the age of 75 is where we see this sort of more rapid increase. The number of deficits people accumulate over time is relatively constant, and that's been shown in sort of various studies. But with this exponential growth, at age 75 is where we see this more rapid increase in the frailty marker. We also see this in other conditions of old age, like dementia, where the incidence of dementia significantly increases after the age of 75, as well as hip fractures, osteoporosis. The other interesting thing to note is that there's marked variability that we see in this frailty above the age of 75. There's very little variability in the younger age group, but after 75, we see this increase in the amount of actual variability of frailty based on age. So Aging occurs at the cellular level. It occurs at subcellular, molecular protein levels. The hallmarks of aging were first published in 2013 by a group of investigators who established that there's 9 sort of main causal links that drive the aging process at both the cellular and subcellular level. In 2022, there was sort of another addition of 6 further factors that had causal links of aging. And in total, there's 13 that have been identified as hallmarks or drivers of the aging process. There's also unknown factors or a bit of randomness as to who gets some of these. But effectively, it's not just one thing that goes wrong or in the aging process. So not just inflammation or chronic inflammation or reactive oxygen species, but numerous things that are interacting and are difficult to predict. But these are the 13 factors that have been identified as driving the aging process. And so these things end up scaling up and causing problems at a tissue level, and then an organ level, and then subsequently a system level. So the example of collagen deposition in atrial tissue might result in atrial fibrosis, and that can increase the risk of arrhythmias and atrial fibrillation. Or the number of calcium receptors in the myocardium would decrease as age goes on due to molecular and cellular changes, and this would result in impaired contraction of the ventricles and eventually heart failure. And as multiple organ systems start to fail, we start to see a system failure and more of a frailty picture clinically. So what is frailty? So there's various definitions of frailty, but I think the commonality between the different definitions is that frailty is age-related. And we certainly see this, that the proportion of people that are frail increases with age. People in their 80s, the proportion of frail is between 30 and 40%. And we also see this sex frailty paradox, that women for any age are more likely to be frail, even though they live longer. And you can see this, the separation of these two curves, women in the red dots and men in the blue dots. But certainly as age increases, frailty is more likely to increase. We also know that frailty is multiply determined. So it's there's various socio-demographic factors, in particular things like low socioeconomic position, having poor childhood education, loneliness, living alone, may all impact someone's frailty status, as well as clinical factors like the presence of disease, polypharmacy, various lifestyle, environmental factors, and biological factors. So it's not just one thing, but multiple things that determine someone's frailty. So from subcellular things to social changes. And frailty also predicts a graded state of increased risk. The more frail you are, the more vulnerable you are to stresses and your ability to tolerate these. So frailty results in a loss of robustness, and robustness is a term that's been taken from the engineering sort of framework of structures, and it's about the ability to resist stress. So a loss of robustness in that sense, and also a loss of resilience, which is the ability to recover from an external stress as quickly. And when people lose both robustness and resilience, they lose physiological reserves, and their ability to tolerate stresses is diminished. So frailty is not a disease in itself, but it can modify the expression of various diseases. And we see this in dementia. So in 1984, the diagnosis of dementia was pathological. It was done to say someone's got definite Alzheimer's dementia. They needed to have a brain biopsy or an autopsy. There needed to be neuropathological findings suggestive of Alzheimer's disease. And so there became a clinical diagnosis of dementia that later emerged. But as in the last decades, where there was more studies looking at targets for beta amyloid, the protein deposition in the brain, and eradicating that from the brain, they noticed that people with Alzheimer's disease, they might have had very little pathological changes in the brain, and similarly, other people with quite advanced disease might have had very little pathological changes. So there was a bit of a disconnect between the clinical picture of dementia, Alzheimer's dementia as a disease versus Alzheimer's disease as a neuropathological process. And what they found was people with very little burden of disease in the brain and the clinical state of dementia were the most frail. And so the link there was that frailty was modifying the disease expression. Those with little pathology but high degrees of frailty were more likely to display clinical signs of dementia. And those that had pathology in the brain but were quite robust or less frail were less likely to clinically manifest these changes of dementia. So most sort of researchers now would know that dementia itself is not a single pathological entity. There's sort of multiple changes in the brain, and pure Alzheimer's disease is very uncommon. There's often multiple changes, including amyloid plaques, Lewy bodies, vascular changes. And so presence of these doesn't necessarily correlate with clinical findings of dementia. So how do we measure frailty? There's two dominant methods that have been available in the literature that are the main methods of measuring frailty. The first is the phenotype of frailty, and this considers frailty as a syndrome of physical weakness, slow walking speed, low physical activity, exhaustion, and weight loss. And having 3 out of those 5 would be considered frail. And because you've got 5 features, you can develop a 6-point scale effectively to grade your degree of frailty. And this is the syndrome of frailty, or the phenotype, developed by Fried and colleagues in 2001. The other popular or sort of dominant method of measuring frailty in the literature is the frailty index. And this considers frailty as a condition where deficits become accumulated over time. And Rockwood and Mitnitsky were the sort of first pioneers of this method. And basically they count the number of health deficits. And these can be a combination of things like signs, symptoms, diseases, disabilities, abnormal lab tests, polypharmacy, functional status. And usually at least 30 are required to make an index. I think in the original one, there was about 92 factors, and they basically count the number of these that are present and divide it by the total number in your index itself to give a number between 0 and 1 as your frailty index. And there's various cutoff points as to what's considered frail, mild frail, moderate and severe frail. So it's not the type of conditions that are present, but the number effectively, and accumulating more of these deficits are the problem in this conceptualization of frailty as a deficit accumulation model. And so what happens is, although that individually these things like hearing impairment or an abnormal lab test aren't predictive of poor outcome, combining these into multiple, or into an index is more predictive of adverse outcomes. Another more popularized method of measuring frailty is the clinical frailty scale. And this is quite a simple tool to use. It's a 9-point scale, which has visual as well as sort of high information data about how to grade someone as frail or between fit to frail. And I think we do this on a day-to-day basis anyway, consciously or subconsciously. We'll say this person is pretty fit, this person's a bit frail, and this person's bedbound and very frail. I guess this helps to numerically score that, so we're all speaking the same language. And this has been shown to have very good inter-rater reliability on multiple studies across different assessors of doing this clinical frailty scale. We've got permission from Dalhousie University to use this at Canberra Health Services. I don't think we're using anything like this at present, and hopefully this will be built into the DHR soon. I've put in some requests through the Clinical Forms Committee so that we can have this as a guidance. It's quite a simple tool. It doesn't require any special equipment, and I think it could be done anywhere from the emergency department to the community to the ward to get a sense of where people are on their frailty levels. So the impact of frailty. So there's numerous studies that show that the worse your frailty score, or the more frail you are, the worse your outcomes. And this is in terms of all sorts of outcomes like mortality, readmission, length of stay, nursing home admission, falls, delirium, all of these outcomes are considerably worse. And this is across various populations, both community and inpatients, and even other populations outside of the aged care setting, such as oncology or surgery. And so it's quite clear that the worse the frailty, the worse the outcomes. I guess what's more difficult to appreciate is the impact that routine hospital care has on people that are frail. So when someone comes in for an acute illness, people may be subjected to periods of fasting for various procedures or for various types of treatment. They might be relatively immobilized because of their acute illness. They might be isolated because of infections or contact precautions, and all of these things for a young person who's relatively fit is a bit of an inconvenience, and they get over it and go home predominantly because they're fit. But for a frail older person, their ability to recover from these things, which are part of routine care, is often more difficult and challenging. And it's particularly the people that fit into into the scores between 4 and 6 in that middle range of frailty. So people that are very fit or generally more robust and able to tolerate these things, people that are in the higher spectrum of frailty are less likely, but people in that score between 4 and 6 are more likely to suffer the effects of immobility, malnutrition, and the effects of hospitalisation. So is frailty modifiable? So this was published nearly 30 years ago in the New England Journal. It was a study of 100 nursing home residents in their 80s, and these residents were given 10 weeks of high intensity lower limb strength training, and they were given this for 3 days a week. And at 10 weeks, at the end of that, they were assessed for their strength. And there was almost a doubling in the people that were prescribed the resistance or high intensity exercise. Addition of a supplement provided some benefit, but a supplement alone had no effect in terms of increasing strength. And so we've known this for a long time, that frailty can be modified. And evidence of this is in some of the research regarding prehabilitation for elective surgery. So people will undergo training prior to undergoing elective surgery to try and improve their physical function and their frailty scores, and hopefully to improve their outcome. So does this work in an acute setting? So this was in a nursing home setting, that previous study, but last year in the Age and Aging, there was a publication about a study that enrolled 370 participants, also in their late 80s, in an acute geriatric ward. And they were randomized to resistance, balance, and walking exercises. They weren't training at as high an intensity. They were only at 30 to 60% of their maximum. And it wasn't done by frontline staff that were already working. It was by additional staff that were there to purposefully do this exercise-based training. And the outcome they were looking at was clinically meaningful improvement in their frailty scores. So in the intervention group, there was a marked improvement of nearly 2/3 of patients improved in their frailty scores in a clinically meaningful way, compared to the controls, where the majority of people were either unchanged or worse in terms of their frailty. So it is possible in an acute setting. I think it requires some sort of creative thought as to how this can be operationalized to improve people's frailty. But certainly the addition of resistance-based training in particular can improve people's frailty in an acute hospital setting. So exercise is medicine, as we all know, but the dose and type matter. And the best evidence for frailty or sarcopenia or loss of muscle mass is resistance training. And gentle-based exercise or walking exercise has no real proven benefit in improving people's frailty. And the best evidence is really for resistance-based training. And that needs to be progressive in terms of how it's done. And people need to be exercising at this vigorous or hard level. This is the Borg rating of perceived exertion, which most physiotherapists would use in terms of assessing people's exertion when they do exercise. And they need to be operating at a level where they are doing, they're not able to do more than 10 repetitions of the same exercise. And this is what sort of most weight training exercise for younger people would be, and it's the same for older people. So I'll show this short video, which is from the see if this works. So this is for the Agency for Clinical Innovation, who have started a frailty task force to combat frailty.
So frailty is something that is more and more common as people get older, although not all older people are frail. And it's very what we call multifactorial, so lots of different things contribute to it.
With resistance training, I guess the evidence is quite overwhelming.
If you go back to the beginning.
Yep.
Frailty is something that is more and more common as people get older, although not all older people are frail. And it's very what we call multifactorial, so lots of different things contribute to it.
With resistance training, I guess the evidence is quite overwhelming that it is beneficial for pretty much all ages, but particularly those that are frail, it does actually improve their health quite a lot.
Well, I think it's made a great difference to my general well-being. Without the exercise, I wouldn't have been able to manage things now as well as I do.
I would like to encourage people. If I can do it, anybody can.
So the basic purpose of resistance training is to make you stronger. But the nice side benefit is that muscle strength and muscle size is actually related to a lot of different chronic conditions. And so when you make someone stronger, they will also perform better in terms of their daily activities. It helps treat their diabetes, their heart disease, their depression, even dementia. So most of the chronic conditions of aging, in fact, have now been shown in very good clinical trials to be responsive to the use of this kind of exercise. We need to educate healthcare professionals and doctors better about how safe it is, how essential it is, how integral it is, how complementary it is to the other kinds of treatments that we use, so that it isn't considered to be something sort of on the outside or, that you don't really have to do, but it's really part of your prescription of care for that individual.
So that was from the Agency for Clinical Innovation in New South Wales, and one of the speakers there was Professor Maria Theotoroni Singh, who is an academic at the University of Sydney and is sort of heading a lot of this research into progressive resistance training. There's proven benefits of progressive resistance training for numerous health conditions, not just frailty and sarcopenia. There's emerging evidence for neurological conditions that there's benefits in terms of outcomes in falls reduction. There's evidence in heart failure, cardiovascular disease, depression, that resistance exercise can certainly improve people's depression, as well as other conditions like renal disease. Type 2 diabetes, I think, is now part of clinical guidelines to include resistance-based exercise. And the best outcomes are achieved when it's measurable, high intensity and progressive with training supervised. Often this is hard to achieve in an outpatient setting. I think there's no real facility or service in ACT that provides this service. And I guess it's an area of deficit, and perhaps in the future with more funding, we'll be able to have the ability to refer to an outpatient service where people can access this type of resistance-based training with supervision. Two areas that I just wanted to touch on in terms of the benefit of progressive resistance training is post-hip fracture. And we do have an excellent orthogeriatric service here that provides fantastic care to people that have had neck of femur fractures. But this study was done for people after they were discharged from hospital. They'd had their acute care rehabilitation and were sent home. And it was in a Sydney hospital over 4 years, and they recruited everyone potentially that had a hip fracture in that time period and wanted to participate. And they were provided 12 months, so a full year of high intensity weightlifting exercise after they'd gone home. And they were working at 80% of the max, and it was progressively increased. And they combined this with a multi-component intervention with nutritional support, osteoporosis care, and they randomized participants to this intervention group or usual care, which is what they would normally receive after a hip fracture. And the results were quite astounding. There was a reduction in mortality by 81%, and there was also reduced odds of going into residential care for this group. They also required fewer assisted devices for mobility and less decline in their ability to self-care. So a significant sort of benefit from resistance training post-hip fracture. Often what we aim for is the baseline mobility, and baseline is really what they were one day before they broke their hip, which is not a high sort of target that we're aiming for. So if we're able to sort of replicate this in the community, the outcomes would be significantly improved, but it requires quite a lot of work and funding. I think in New South Wales, in one of the hospitals, they're trying to start this in Canberra Hospital. So hopefully we'll see some more information about translating this into clinical research, into clinical work. The other area which is quite interesting and an area that's still evolving in terms of progressive resistance exercise is a trial that's being done in University of New South Wales or with Professor Henry Brodati called Maintain Your Brain, and it's to see if resistance-based exercise can delay the onset of dementia. So people that are at risk of dementia in the 55 to 77 age group that have one or two risk factors, they're given an internet-based resistance training program. So there's no face-to-face interaction, and they combine this with some other additional multimodal targeted interventions. And the follow-up period is 3 years, and the preliminary results show that there's less cognitive decline at that 3-year mark. I think the results are yet to be published, but preliminary results are suggesting that there's improvement. And I guess this reinforces the fact that the brain and the body are very much connected. What you do in the body impacts what happens in the brain. Physical exercise, in particular resistance, can have profound impacts on the brain through both hormonal pathways and other pathways that impact on cognition and brain function into the future. So these interventions are looking at individuals, but I guess there's more of a desire to look at whole systems-based changes. And in 2019, the Queensland government dedicated $30 million to this Frail Older Persons project. And this was headed by the Clinical Excellence Commission in Queensland. And it was a redesign initiative where they pretty much redesigned the health service using existing services and scaled them up across the entire state to see if they could target frailty. And they looked at 5 key areas. One was identification of frailty, which I guess is something that we could do better as well. There's certainly scope for being more consistent with identification using a measurable, a verified tool to measure frailty. They also have this service called the JEDI service, which is a geriatric emergency department intervention. And this is having a presence of geriatric service in the emergency department to try and help facilitate people to return back to nursing homes where aggressive intervention may not be necessary, particularly in people in the severe frail group. And there's also an intervention there called Eat, Walk, Engage, which looks at increasing nutrition, mobilisation and social engagement for people admitted to hospital. And that started as a small scale project, but through this Frail Older Persons has been scaled up to include much of the state of Queensland. And as mentioned, New South Wales has started this frailty task force. And again, their goals include the identification of frailty, as well as other more targeted interventions, particularly for that phenotype of frailty as a syndrome, for things like early mobilisation in hospital, polypharmacy, deprescribing, and optimising nutrition for people living with frailty. So as we all know, the population is ageing. A large proportion of the current population is in this baby boomers group. So this is data from the census from 2021. So you can add 2 years to the age brackets that are presented there, but the leading edge of the baby boomers are approaching 75 or turned 75. And we'll see more and more people into that 75 plus age group in the next few years and decades. And we also know that genes and environment are the 2 key factors that impact on disease expression. Some of these are non-modifiable, but certainly modifiable. But this is true for most people in the younger age group. But as we see, as people age, aging becomes the dominant risk factor for many diseases. It's a big risk factor for cancers, cardiovascular disease, respiratory disease, and pretty much dominates in terms of risk. So there's been a search for a cure for aging for decades. I think the earliest studies in this in the 1930s with caloric restriction, showing that if you fed mice at 30% less than their normal dietary intake, they live for longer. There's also great evidence from preclinical studies about aerobic exercise and high intensity interval training. There's lots of pharmaceutical agents that are being tested. So rapamycin is one of the drugs that has been shown significant interest in terms of longevity and increasing both lifespan and health span in mice. So this is a macrolide antibiotic with immunosuppressant properties. It's used in the transplant population. If anyone watched Insight last night, there was a doctor that was self-prescribing rapamycin and also to patients as well, with the idea of living longer. There's trials of metformin and resveratrol, which is an antioxidant present in the skin of grapes, as well as compounds in garlic. These three in red, polypharmacy, high-fat diet, and whole-body irradiation, have been shown to have adverse effects in terms of aging and longevity. And polypharmacy has been modelled in mice models where they were prescribed 5 commonly prescribed medicines, and they showed that these mice had significant increase in frailty on their measures. They also noticed that deprescribing those medicines showed an improvement in the mice's function. Unfortunately, most of the studies are done in mice models. I think there's slowly data emerging in non-human primates, but the ability to translate this into a human sort of clinical world is still unclear at this point in time. So the geroscience hypothesis, so geroscience is a field that's emerged in the last 15 years or so, is basically that the biology of aging is sort of more and more understood in terms of the cellular, subcellular changes that occur. And our current approach is to target individual diseases one at a time. So improving survival in cancer, improving survival in cardiovascular disease. But the underlying driver often is age-related changes for these conditions. And if we're able to allow people to live longer and delay the aging process, either through environmental changes or pharmacological agents, then we're able to target all of these conditions all at once effectively, and delay the onset of all of these conditions, and thereby allowing people to live longer with healthier lives. And although at some point people have to die, they might have a compression of morbidity, which means that in the last few years of the last period of their life is the greatest period of morbidity, rather than the last 10 or 15 years living with disability. And so this is the hypothesis of geroscience, that through some sort of intervention, people's aging or ability to live longer will be delayed. So the future of aging research is perhaps in our lifetime, we might see a biomarker for aging, a marker that we're able to detect in blood or serum that gives an indicator of people's biological age. Although there's lots of potential targets, nothing's been validated at present. There's already trials of senolytics, drugs that slow the aging process in humans, and perhaps in our lifetime we might see a therapeutic agent become available. Although it's the thing of perhaps science fiction, I think the emerging field of geroscience with the explosion of research shows that this might be a realistic possibility in our lifetime. And there's also a need for translational medicine, so taking these preclinical studies into a clinical realm. Perhaps in the future, the use of machine learning algorithms and AI technologies might allow us to tackle some of the complexities of aging, that there's multiple factors involved, both biological, cellular changes, social interactions that impact on the aging process, to provide a more personalized approach to therapeutic targets to aging. And certainly more clinical trials with a view not just to increase lifespan, but to increase health span will be the eventual goal. So in summary, not everyone ages biologically at the same rate. Frailty helps to clinically characterize this variation in aging. Exercise is certainly medicine. I think we should prescribe progressive resistance training to all people in the older age group at least. I think there's benefits in the younger age group as well. And geroscience may present opportunities to modify the aging process and perhaps reduce the burden of chronic disease and disability in the future. All right. I thought it. Right. Yeah.
Sorry. Well, thanks, Malith, for a comprehensive and very interesting and thought-provoking review. As somebody in his middle booming years, it's a topic close to my heart. And I was mentioning to Malith that there's been a recent review in Lancet Diabetes and Endocrinology of the endocrinology of aging, which is a topic that alludes to the Geroscience concept that Malith discussed in terms of what is physiological versus pathological. And this is a field that is expanding. So I would ask if there are any questions from the audience. Sure.
Hello, Billy Clemens from AMU. Thank you very much for excellent talk. Just a few points and at the end, one question. A few comments is genetics is before everything. You might find one who has a ischemic heart disease and end-stage kidney disease, and he can still run a marathon. And one who is no comorbidity at all, and he's very frail. Number two, now there is biomarker in the research to predict frailty. The biomarker is the drop in adiponectin and decrease in quantity or quality of red fiber type 2. Third comment, now it has been proven by at least 26 studies, at least, that coffee protect against frailty, Parkinson's, dementia, demyelination, peripheral neuropathy, the liver fibrosis, adenocarcinoma of the esophagus, and gastric carcinoma. My question to you, did you come at your research at any study which correlate between frailty and growth hormone?
Thank you for those comments. Yep, and I'll be happy to join you for a coffee after if you like. But I haven't seen any specific studies about frailty and growth hormone specifically, but I welcome any comments that you have about that. I think there are emerging biomarkers certainly for both frailty and aging. I don't know how validated they are in the general population, and perhaps it's an emerging area of research. I'm not certain about growth hormone specifically. Yeah.
Yes, because in adult population, people who have easy ability and decreased quality of life for no good reason, and the growth hormone borderline or just below borderline, they benefit from growth hormone.
Yeah.
And I think maybe the endocrinologist.
Yeah.
Well,
I think insulin-like growth factor is, yeah.
Yes, so that's actually
Yeah.
a difficult area. It was discussed in that review that I mentioned in April, Lancet Diabetes and Endocrinology. It's actually, there is some evidence that growth hormone replacement, if your growth hormone deplete, but remember that IGF-1 is age dependent as a biomarker, may be of benefit, but there is also evidence that in animal models that growth hormone restriction may be of benefit in terms of longevity. So it's not a clear area at all, and it is the subject of ongoing research. We've got a couple of questions online. Again, it's a related question. Can I ask whether you can expand, my eyesight's frailing as I age, on frailty as a prognostic indicator for dying?
Yeah, that's a great question. Yeah, so I think frailty could certainly be used as a prognostic indicator. There's numerous studies that show that increased frailty is associated with bad outcomes or worse outcomes. often the difficulty with using frailty as a prognostic marker is a lot of uncertainty around prognosis from frailty scores itself. Although with, for example, oncological studies and people with various degrees of malignancy at various stages, there's more robust data about life expectancy, whereas in the multimorbid older person with frailty, there's a significantly increased degree of uncertainty about what their trajectory might be. They may live for sort of 6 months, 12 months. I guess you get a sense that they do have increased frailty, but it's very hard to predict, I think, in terms of people's life expectancy based on frailty alone. And perhaps because of the complexity of aging as well as the complexity of frailty, that it's multiply determined and there's so many factors involved. I think certainly it should be part of the consideration for palliative care and discussions around sort of goals of care and advanced care planning. People in the higher frailty group should certainly have early discussions about what their intended goals of care are and whether we are overdiagnosing and overtreating people in that age group. And that's an important discussion, but very much individually sort of driven and individually discussed because of the wide number of factors that might be implicated there.
Thank you. Yes.
Look, talking about do you have any data regarding ethnic groups? What history before?
So the question for those online has to do with information regarding ethnicity and occupation, etc.
That's an interesting question. Yeah, so frailty is I think impacted by both ethnicity and socioeconomic status. So people that were in the poorer groups or more disadvantaged were more likely to be frail on lots of sort of systematic reviews and studies of that group. I think there's a wide range of ethnic sort of variation in terms of both genetic and environmental factors impacting that as well. I haven't come across any specific study comparing different ethnic groups in terms of frailty scores, but I imagine there would be quite sort of variability depending on ethnicity in terms of likelihood of having frailty and frailty at any age. Certainly gender is a risk factor. Females are more likely to be frail. But I might have to get back to you about specific ethnic studies in frailty.
Sure.
I'm Faisal, Geriatrics AT, and thanks, Mel, for a nice presentation. So I've got two questions, and specifically the Geroscience, our current knowledge of all the comorbidities and also the aging process. When that is combined in the Geroscience, have you come across that in the future when we have more knowledge, whether there will be a new therapeutic targets based on this Geroscience, like maybe based on the epigenetics, or what, like it will change the whole spectrum, the way we treat diseases now in the future?
Yeah. So yeah, I mean, it's a great question, and I think that's the aim or the goal of Geroscience, is to find something that will a target for treatment. And I think it's quite complicated because, as you can see, the hallmarks or the drivers of aging are not just one; they're multiple. And so it may not just be one individual target, and it may be personalised for an individual. So people might have to undergo a genetic analysis to get their entire DNA sequence and work out what sort of potential targets might be beneficial for them, and that perhaps combined with various environmental factors as well. And that's where more complex computer algorithms might play a role as well in determining what things would be beneficial for individuals at an individual level.
You might make this the last question. It's time is getting away from us.
Thank you, thankfully. Excellent talk. Just a question about, exercise does have a important role, especially the resistance. Did the effect of exercise remain beyond we finished it? So for example, we have that 1 year progress.
Yes. Yeah.
And then looking at next 5 or 10 years, was the effect is still reproducible?
Yeah. So thanks for the question. Yep. So the HipFit study, although it was a 12-month trial, the study did look at data beyond 12 months. And they reanalyzed people sort of, I think they ran out of funding after the initial 12 months. It was an HMRC funded project. And at sort of 2-3 years, people that were in the intervention groups did have ongoing benefits. But I think by about the 3 or 4 year mark, they had sort of gotten close to where the other group were. So I guess resistance based strength gains can be easily lost as well. And they need to be sort of continued on an ongoing basis. And that's quite important.
Thank you.
All right. Well, I might draw the session to a close, but I'd like you all to join with me in thanking Malith for a very interesting session.
We will give you a copy now.